Good evening, everyone. You are welcome to this session of surgery class, where today we'll be discussing gastric cancer. Now, gastric cancer is a very notorious malignancy, and in the past, because of the high amount of mortality it caused, it used to be referred to as the captain of the men of death. And adenocarcinoma of the stomach is the leading cause of cancer death. It's a leading cause of cancer death worldwide, and is the second and fourth most common cancer in males and females, respectively. Of course, we know lung cancer still remains the commonest cause of death worldwide in males, and the second being gastric cancer, third colon cancer, while in females you have gastric cancer being the fourth cause of death, cause of cancer death. Now, the case fatality ratio of gastric cancer is higher than for common malignancies like colon, breast, and prostate cancer. So gastric cancer is a very aggressive tumor, which the survival rate is very poor. And of course, it has a very poor prognosis due to some certain factors we will see shortly. And we should know, despite advances in diagnosis, the disease is usually detected after invasion of muscularis propria. Now, the reason why gastric cancer still remains a malignancy with poor prognosis is because of two factors. Late presentation. Most of the patients, they present when it has become an advanced disease. And the non-specific symptoms they present with, and most of the time you see patients treating for other conditions like peptic ulcer disease. And before they present to the hospital, it's already a malignant advanced case. So this is the reason, because patients experience vague and non-specific symptoms in the early stages of the disease. And of course, before they present, it's already advanced, and hence it has a poor prognosis. And we should know the classical triad of anemia, weight loss, and refusal of meat-based food. It's seen only in advanced stages. Now, most of the patients with gastric cancer, weight loss is a common and prominent feature you see in them, and anemia. And the anemia they usually present with is a chronic type. And they have early satiety, as well as refusal of feeds that may trigger pain when they take those feeds, like meat-based foods. But generally, they have early satiety and anorexia. Globally, gastric cancer accounts for 989,600 new cases annually, and 738,000 deaths annually. You can see majority of those diagnosed with this disease die from the disease. And of course, the Asian region Japan has the highest incidence of this condition in the world, where it accounts for 75% of cancer death. Of all the cancer deaths in Japan, gastric cancer accounts for 75% of deaths. Now, we should know the incidence is seen in the elderly. It increases with age steadily up to the age of 80. However, the peak age is seen in 55 to 65 years. Now, you can have patients presenting at a younger age, okay, especially when there are genetic components to the disease. They tend to present at a younger age and they tend to be more aggressive. And it shows a male preponderance in almost all countries, with 2 to 4 times higher among males than females. So the male-female ratio is a range, commonly 2:1, ranging to 4:1. So that is how common is it among the male sex. Now, you should know that cancer of the stomach has a very poor prognosis, and a 5-year survival rate is only around 20%. This is a very poor prognosis. 5-year survival rate is only 20%. Now, the best prognosis you get is a 5-year survival rate of 60%. And this is only when they are picked early. And of course, you know, most of them don't present early. For you to get a 5-year survival of 60%, they must present without any form of metastasis. Gastric cancer can develop in both the proximal and distal region of the stomach. Today, we are not going to describe the anatomy of the stomach because in our previous lecture on peptic ulcer disease, we've already described the detailed anatomy of the stomach. So you can refer back to our previous lecture. Now, these cancers could involve the proximal part and the distal part of the stomach. But you should know that the distal gastric cancer predominates in developing countries among Blacks and those with low socioeconomic status, while the proximal part is commonly seen in developed countries with high socioeconomic factors. Now, you will see the reason because the dietary factors, H. pylori infection, is the major risk factor for developing distal tumors. And you know, the incidence of H. pylori infection is commoner in the developing countries compared to the developed world. And you know, 50% of the world's population are affected with this H. pylori infection. And for this H. pylori infection to be present for up to 10 years in an individual is a risk factor for developing gastric cancer. Proximal tumors are more common in developed countries among whites and in high socioeconomic cases. Major risk factors for proximal cancer are gastroesophageal reflux disease, and obesity. You can see, gastroesophageal reflux disease and obesity are commoner in the developed world as compared to our own environment. Now, but you should know that there is steady decline in the incidence and mortality of gastric cancer in most affluent countries. This is being attributed to what? Change in their dietary pattern and storage, food storage, improvement of storage facilities, good refrigeration of our foods have constantly declined the incidence of this disease and control of H. pylori infection. You should know that most conditions that result from infection are decreasing steadily in the developed countries as compared to our own region. Now, the risk factors for gastric cancer. Now, H. pylori infection, it's one of the most important risk factors for this disease. There are environmental risk factors which include the diet of the patient, the lifestyle of that patient, including smoking and alcohol ingestion. There are genetic factors which we will consider. There are some pre-malignant conditions that are risk, and others include Epstein-Barr virus, which accounts for 10% of adenocarcinoma, obesity, and low socioeconomic factor. So we are going to consider each of these factors separately and see how they are implicated in the development of gastric cancer. Helicobacter pylori infection. As we all know, as we've seen, that the risk factor or etiology for gastric cancer is what? Multifactorial. There are multiple factors. However, more than 80% of cases have been attributed to Helicobacter pylori infection. This is the most important etiologic factor for developing gastric cancer. And you should know there's significant increase in risk in patients with H. pylori infection, okay, that lasts for more than 10 years. The combination of this factor, that is the virulence of this organism, presence of virulent organism, a permissive environment, and a host with genetic susceptibility makes this organism thrives better. An organism that the urease secreting ability and some other factors confer virulence to this organism. So presence of H. pylori in combination with some other suitable factors increase the risk of developing this malignancy. Now, what are the several factors in the H. pylori that makes it an organism notorious for this condition? Now, you should know that the bacteria secrete several products that cause gastric mucosal damage. Gastric mucosal damage, such as urease, protease, phospholipase, ammonia, acetaldehydes. These are substances that are produced by the bacteria that cause disruption of the gastric mucosa. And after that, they also disrupt barriers at the gap junctions in between cells. H. pylori disrupts gastric barrier function via the urease-mediated myosin II activation, not only producing cells that disrupt mucosa, they also disrupt intercellular bounds. Now you should know they cause DNA damage, and when they damage DNA, they prevent mechanisms and processes that will cause DNA repair. H. pylori infection induces the production of reactive oxygen and nitrogen species and suppresses the host antioxidant defense mechanism, leading to what? Oxidative DNA damage. They produce oxidative products and suppress the antioxidants of the host, and this in turn will lead to an oxidative DNA damage. Okay, so you should also know that they decrease DNA repair activities and inducing mutation in the mitochondrial and nuclear DNA. Aside disruption, they impair the repair of this DNA. And they go ahead to cause formation of mutagenic substances through inflammatory mediators or by impairing mismatch repair gene. So you can see via several mechanisms we highlighted, H. pylori can trigger a lot of damages on the cell. Now there's a virulent strain, the CAG-A, that is the cytotoxic associated gene A. This strain increased the risk of non-cardia, that is other parts of the stomach, specifically antrum at the distal stomach. Okay, non-cardia gastric cancer of both intestinal and diffuse types. We'll talk about the types of gastric cancer, but not a risk for cardiac cancer. So the CAG-A strain is a risk for producing, okay, cancer at the distal portion of the stomach. Acting via CAG-A, it activates growth factor receptors, increases proliferation, inhibits apoptosis, and promotes invasion and angiogenesis. H. pylori has thus been declared as a class 1 carcinogen. These are agents that have been identified to cause cancers. Now, this table summarizes various mechanisms via which the H. pylori can trigger formation of cancers. Membrane-bound factors, they secrete factors, and they are injected factors. And the cellular response are via various mechanisms: adherence, inflammation, apoptosis, motility, and proliferation. And they lead to a pathological outcome: persistent colonization, inflammation, and so on. Now, we've discussed the H. pylori as a risk factor. We'll talk about environmental factor as a risk for developing gastric cancer. Now, dietary, salted, preserved diet, smoked fish, all these are types of food that increase nitrosamines in the stomach, which in turn are all carcinogenic. Poorly preserved food, nitrates, and nitrites, nitrosamines are all risk factors for gastric cancer. So in poorly preserved food, you have a lot of nitrates, which are converted to nitrites, and other nitrosamines, which are all carcinogenic. But with the improvement of preservation of foods, you reduce the risk of all these products in the food. So preservation is not just only just by the bacteria. You just kill the bacteria. You say, okay, I'll keep my food. By the morning, I'm going to heat it to kill the bacteria. No, you have to even prevent them from proliferating by refrigerating the food so that they don't lead to generation of all these products that are carcinogenic. So we know that vegetables, fruits, vitamin C, E, A, calcium are all protective. So in our diet, when you add all these food products, especially fruits, our diets containing vegetables, we should know that they are all protective against gastric cancer. Vitamins, vitamin C, E, A, calcium are protective, not only against gastric cancer, but of course against other gastrointestinal malignancies. Smoking and alcohol are implicated in a lot of malignancies, not only gastric tumors. Now you should know that gastric bacteria converts nitrates to nitrites, which are carcinogens. Gastric bacteria are abundant in achlorhydric patients that do not secrete acid, because acid is actually required for prevention of proliferation of this bacteria. As we mentioned, refrigeration reduces the risk of nitrate-rich preserved food. Now, the next risk factor we'll talk about is genetic factor. You should know that 8 to 10% of gastric cancers have familial components, and the implicated conditions are P53 mutation, which is the commonest genetic mutation for patients with gastric cancer, and you see that in Li-Fraumeni syndrome. BRCA2 mutation, ECAD-Herin mutation, hereditary non-polyposis colon cancer family, Bellin-2 syndrome, where gastric cancer form a component of that cancer family syndrome. Peutz-Jeghers syndrome, familial adenomatous polyposis. Now, the various genetic abnormalities that are noticed in these patients are deletion, deletion that is seen in P53 mutation, E-cadherin APC, overexpression, like overexpression of HER2 receptors, microsatellite instability, and DNA aneuploidy. And we should know that the most common is the P53 mutation. Now, pre-malignant conditions. Now, chronic atrophic gastritis is the most common pre-malignant condition that is associated with gastric cancer. Chronic atrophic gastritis, the most common pre-malignant condition. Now, in 15 years, 10% of patients with chronic atrophic gastritis develop gastric cancer. H. pylori is implicated in the pathogenesis of chronic atrophic gastritis through a pathogenesis known as the chorea cycle. You should go back and read about chorea cycle, and it describes 3 distinct patterns: the autoimmune type, the hypersecretory type, and the environmental. Okay, and it could be associated with pernicious anemia. Now, polyps, especially large hyperplastic polyps that are greater than 2 centimeters, are pre-malignant condition, especially those polyps that are located in the fundus. They could be a pre-malignant condition. When there are intestinal metaplasia from any factor, maybe reflux or whatsoever the cause may be, it's a risk factor for malignant transformation. Benign gastric ulcers, giant gastric ulcers that are greater than 3 centimeters and usually located at the greater curvature are regarded as a pre-malignant condition. Gastric remnant cancer after partial gastrectomy and gastrojejunostomy, more than 10 years after the initial operation, the remnants of that stomach can undergo a malignant transformation. Because of the continuous reflux of bile from the small bowel into the stomach, they can present with gastric cancer. Menetrier's disease is also another pre-malignant condition. Now we'll talk about the classification of gastric cancers. There are various types of classification. However, the Lorentz classification is the commonly used classification for classifying gastric cancers. There are several other methods, like the Japanese classification, that classify the superficial, which are the early, and the deep, the advanced. The Bowman is for advanced. WHO is histologic classification. The molecular classification based on receptor. Then you have the mean classification. We will see them, but we might not discuss the details of all that. The Lorentz classification is the commonly used classification of gastric cancers, which classify the cancers into intestinal type that assume the intestinal mucosa, the diffuse type which is also known as the infiltrative type, or Linitis plastica. Just like a plastic bag, the tumor completely infiltrates the wall of the stomach, or it could be mixed. The Lauren classification separates gastric adenocarcinoma into two primary subtypes, intestinal and diffuse, and tumor exhibiting features of both intestinal and diffuse type in 25%, 15 to 25%. Majority of the tumors are intestinal type. So these particular types have their characteristic features that varies. The intestinal type, the incidence is common in high incidence area, okay, but is decreasing steadily in incidence. So you should know this is the commonest type, okay, and it is commoner in high incidence area, but it's steadily decreasing. Now, the diffuse type is relatively common in low incidence area, and it appears to be increasing. Now, the age and sex, but basically you should know that this intestinal, the diffuse type has a poorer prognosis as compared to the intestinal type. The outcome of the diffuse type is poorer as compared to the intestinal type. As you can see, the age and sex predilection, when you start seeing the uncommon things taking precedence in a disease condition, so it makes it more aggressive, because generally we say gastric tumors are commoner among males as compared to females. And you can see now the intestinal type is commoner in males, while the diffuse type is commoner in females and younger. So you tend to see the ulcerative type in younger individuals and that are females. Okay? Okay. The environment. Now, you should know that the intestinal type is associated with environmental influence, while the diffuse type is not associated with environmental influence, probably influenced by the genetic factors. Okay. Now, the tissue factor, the intestinal type arises out of the chronic atrophic gastritis with intestinal metaplasia, dysplasia, and malignancy, while the diffuse type arises from a single cell mutation. So it is genetic in nature. Now, that is the commonest way gastric cancers are classified, using the Lauren classification. Classify them based on the appearance of the mucosa, whether intestinal type, assuming intestinal mucosa, or diffuse or infiltrative, which is the Linitis plastica, okay, that lacks the glandular type nature of the intestine. Okay. Okay. Now we should know that another way of classifying them, which could be early or advanced. Early or advanced. And this is the way the Japanese classification classify gastric cancers. What you should know about this, when you say gastric cancers are early, what does it mean? It means it is limited to the mucosa and the submucosa. Whenever it bridges the submucosa and go beyond that, it becomes an advanced gastric cancer. Okay? It is common in Asia where high frequency is noted, and thus they do aggressive surveillance to detect them early. Now, you should know that even 10% of patients presenting at this stage already have a lymph node metastasis. Now, in the T staging, whenever you see T0, it is early. You are talking about an early gastric cancer. So this early gastric cancer have type 1 to 3. This T0 you are seeing, type 0, 1 to 3, are subclassification of early gastric cancers. Okay? They are all referred to as superficial cancer. So it could be type 1, which is protruded, type 2A, which is superficial and elevated. From this image, you can see what it means. It is still superficial, but is what? Elevated. This is flat, type 2B. Then type 2C is superficial but depressed. So you have elevated, okay, superficial, and depressed. Now, this superficial now has, whether it is elevated, whether it's flat or depressed. So this is the macroscopic classification of early gastric cancer. Now you can see, as I told you, it is the Japanese that classify them into early and advanced. And from what we just described, it still describes the early classification, which you can see type 1 is protruding, then type 2 are all superficial, which could be elevated, flat, or depressed. Then type 3 of the superficial is excavated. Now you have the deep or the advanced classification. Okay, here it has gone beyond the submucosa. Type 1 has a mass. Type 2 is ulcerative. You can see it has involved the muscularis propria now. When it goes beyond the mucosa and submucosa, it's already advanced. You can see it's involving the muscularis propria now. So type 1, it's involving muscularis propria. There is mass. Type 2, that mass is ulcerating. You can see it has ulcerated. Type 3 is ulcerative and what? Infiltrative. So it's ulcero-infiltrative. And type 4, it is diffused. Now, when you see Bowman's classification, is just a classification of advanced. They don't talk about early. Anywhere you see Bowman's classification, nobody is talking about early gastric cancer. Once you see Bowman's, it's an advanced cancer. Okay? Type 1 is just as we discussed the previous advance, so polypoid fungating, ulcerated, infiltrating, type 1 to 4. I told you the WHO is the histologic classification, and you can see the various types of adenocarcinoma could be papillary adenocarcinoma, tubular adenocarcinoma, mucinous adenocarcinoma, signet ring, okay? Then it could be adenosquamous, squamous cell carcinomas, small cell carcinomas, undifferentiated, and others. And this is the Lorentz classification, which I told you is the commonest classification that is used, which is the intestinal type, which is the commonest, then the diffuse type, and the unclassified, or you can call this the mixed type. Then you have the main classification, which could be expanding or infiltrating. Now, the TNM is a way of staging gastric tumors. The T is the tumor, N is the lymph node involvement, and M is metastasis. This is very important in the treatment of gastric cancers. It's very important you know the level of invasion as well as the number of lymph nodes that are involved, because after surgery or during surgery, you want to know the level of lymph nodes and the stages that are involved. This will determine the extent of your treatment. Now, how do gastric cancer present? As we mentioned earlier, that most of the patients present late, and this is what confers poor prognosis to this disease. They usually present at stage 3 or stage 4. It has gone beyond the submucosa, it's in the muscularis. It has gone beyond the muscularis, or even with a distant metastasis. If you look at these TNM staging, when a patient is presenting with this T3, okay, it has even penetrated the subserosa, okay? It's involving the peritoneum, or you can see stage 4 is already involving the adjacent structures. Now, you should know this is very important. That's why active surveillance of any patient with peptic ulcer disease is very important. Active evaluation with endoscopy. In fact, you don't say a patient is a known peptic ulcer patient until you have evaluated with an endoscopy. Now, weight loss, anorexia, and early satiety is a triad of gastric cancer. Weight loss is very prominent, and they have early satiety. In fact, they could have abdominal pain, epigastric. This epigastric pain could be burning in nature, okay? And this pain is aggravated by feeding, and it is relieved by vomiting. It is very important. If you see any patient that is more than 50 years, that is developing a recent onset dyspepsia. This is very important. Any patient that is greater than 50 years, developing recent onset dyspepsia. Within 1 year, you start having epigastric pain. You have to take this seriously. And you have to do an upper GI endoscopy for that patient. Okay, so they have epigastric pain that is burning in nature, aggravated by feeding, relieved by vomiting. In fact, you see some patients, they go as far as triggering vomiting to feel relief of that pain. Some patients might have lump in the epigastric region, which could be as a result of an antral tumor, or it could be an enlargement of the left lobe of the liver. Now, patients can present with acute gastrointestinal bleeding where they present with hematemesis, but they may be bleeding gradually, presenting with melena, or when it is massive, they will present with hematochezia. But most of the time, they have chronic blood loss, and they will present with iron deficiency anemia. Now, they can have dysphagia if the tumor is at the cardia of the stomach. Some of the patients will present with paraneoplastic syndrome, Trozier syndrome, acanthosis nigricans, peripheral neuropathy. Now, let me still draw your attention again to any patient that is greater than 50 years, presenting with recent onset dyspepsia. Okay, you should quickly evaluate this patient for gastric cancer. Okay, they may have weight loss, easy fatigability, anorexia, and early satiety. You have to take such patients seriously. Now, physical examination, you might find a normal examination other than the weight loss patient might have. When you see specific physical signs telling you maybe it's an advanced disease already. Epigastric mass is only seen in 25%, which could be antral mass or left lobe of the liver that is enlarged. Patients may have signs of gastric outlet obstruction. They'll be having recurrent vomiting. They'll be having recurrent vomiting of stale feeds. Okay? They are eating 2 to 3 days previously. And this vomiting is what? Non-bilous. Now, for the physical examination, these are symptoms of GOO. For the physical examinations, For GOO, you have succussion splash. I have hepatomegaly, 10%. You might have left supraclavicular lymphadenopathy that is called Virchow node. Virchow node. Left supraclavicular lymphadenopathy. That node is called Virchow node, and the sign is called Trozier's sign. And of course, is deposition of intra-abdominal tumor at the junction where the thoracic duct enters the internal jugular vein and the subclavian vein on the left side. So they present with Virchow node. They could have left axillary lymph nodes that are called Irish nodes. Sister Mary Joseph's nodule are deposits on the umbilicus. Krukenbach's tumors are deposits on the ovaries. And Bloomer shelf is deposits at the pouch of Douglas or rectovesical pouch following transperitoneal spread of the tumor. Now, how do these tumors spread? They could spread via lymphatics involving various tiers of lymph node in the abdomen. Okay, there are 3 tiers of lymph node in the abdomen. Commonly, we use 3 tiers of lymph nodes in the abdomen. Those that are around the stomach, those around the major vessels, and those around the para-aortic group of lymph nodes. So they could spread via the lymphatics. They could spread to the adjacent structures. If you remember, the structures that forms the stomach bed, the transverse colon, the pancreas, the spleen, okay, all these structures can be invaded by the tumor. And when the tumor invades the transverse colon, they can form gastrocolic fistula, which is an internal fistula. And when such a fistula occurs and patient starts vomiting, you'll be seeing fecal matter inside their vomitors because it has already connected with the transverse colon. Now they can spread via the bloodstream to involve the liver, lungs, bones, which is uncommon. Then transperitoneal spread. You can have spread of this tumor in the peritoneal surface. And after treatment, you can have recurrence after resection of the tumor. Now you should note that the metastasis to intra-abdominal lymph nodes, peritoneal surface, and liver is 60 to 80%, 30 to 50%, and 25 to 40%, meaning spread to intra-abdominal lymph node is the commonest intra-abdominal spread. That's why in the treatment you shall see, you don't just resect the tumor alone, you must go along with the draining lymph node. And you should know that lymph node metastasis depends on the level of invasion. deeper the tumor invasion, the more affectation of lymph nodes. Now, liver metastasis is common with the intestinal type, and peritoneal deposits is common with the diffuse type, if you remember the Lauren classification. Now, this is also another important aspect of gastric tumor investigation of a patient with gastric tumor. You do an upper GI endoscopy. Upper GI endoscopy to visualize the stomach and duodenum. Now, when you visualize the tumor in upper GI endoscopy, if there is a tumor, you note the location of that tumor and characterize the features. Then you know, because you are going to report that, then you take biopsy for histology and immunohistochemistry. Because if you remember, among the genetic abnormality, you have overexpression of HER2 new receptor. And this also is a form you can target this receptor using a targeted therapy, trastuzumab. Okay, so upper GI endoscopy, you visualize the tumor in the stomach, you characterize it, you take biopsy for histology and immunohistochemistry. Now you can do barium meal when upper GI endoscopy is not readily available, which will show a filling defect. It will show a filling defect. It can show craters. Now, the type of barium meal that is done is a double contrast. However, this is not commonly done because of the advent of upper GI endoscopy and biopsy. Now, endoscopic ultrasound scan, you want to assess the depth of the tumor. How far has it infiltrated the wall of the stomach? And it can also pick lymph nodes that are greater than 3 millimeters. So, endoscopic ultrasound scan pick lymph nodes that are even smaller compared to that is picked by the CT scan. So contrast enhanced CT scan will assess the tumor, its location, and its relation to the adjacent structure. As we mentioned, that this tumor could invade the bed. With CT scan, we will be able to determine if this tumor has invaded the adjacent structures. You can also pick lymph nodes that are greater than 10 millimeters. When there is metastasis to the liver, you can pick that with CT scan and also presence or absence of ascites. You can do a diagnostic laparoscopy where laparoscopically you can look into the peritoneal cavity to see if there are peritoneal deposits, if there are nodal metastases, if there is liver deposits. And you can also take sample of fluid for cytology. In case you don't see any peritoneal deposit, you take peritoneal fluid for analysis, for cytology. Now, PET scan will evaluate the whole of the body, okay, for micrometastasis. And when you further improve with a PET CT scan, it will give you the anatomical feature of that deposit, because the PET will just show you activity. it's using 18-fluorodeoxyglucose to assess, okay? But if you use PET CT scan, it will further characterize that site of micrometastasis. You do other baseline investigations like food blood count to check for anemia, urea electrolyte creatinine, liver function test, grouping and cross-matching, and so on. Treatment. Now, when you are treating cancers, you downstage them. And downstaging tumors are called, with chemotherapy use, downstaging tumor is called neoadjuvant treatment. Now, use neoadjuvant chemotherapy to downstage the tumor so that it can be resectable, okay? But however, if it is already advanced and you cannot downstage, the primary treatment here will just be chemotherapy. And there are various forms of chemotherapy we use. Traditionally, we use the ECF. Traditionally, we use the ECF. Epirubicin, cisplatin, and 5-fluorouracil. However, because of toxicity, you can combine two different chemotherapy. It will reduce the level of toxicity when compared to when you are using 3 regimens. And of course, you don't use 1 regimen because you want to avoid resistance, and you want to use chemotherapy that act at different sites with different mechanisms of action. So the first line, the preferred regimen, is 5-fluorouracil oxaliplatin, 5-FU cisplatin. Capecitabine is an oral form of 5-FU oxaliplatin. Okay. Now, these are various regimens. And for patients that have HER2/neu overexpression, you can add trastuzumab to their treatment. These are other forms of chemotherapy that are second-line treatment. Now, the surgical treatment, this is a consensus of NCCN and the ESMO on the surgical guidelines for treatment. But I won't go into this detail. I'll just go straight ahead to mention the operations that are done. But you should know that resection, you do a radical gastrectomy if you are aiming at cure. When you say gastrectomy, they are different. That is surgical excision of the stomach. Now, if this is the stomach, you could do a total gastrectomy, completely removing the stomach. It's a form of gastrectomy. Okay? You could do a subtotal where you take up to 80% of the stomach. You could do a partial gastrectomy. You could do a hemi-gastrectomy. These are various forms of gastrectomy. But usually, for malignancy, total or subtotal gastrectomy are the types that are involved. When you say R resection, there's this concept you see in textbook, R resection, R1, R2, R3 resection. In your textbooks, you will see D1, D2, D3. They are simple. It shouldn't confuse you. Anytime you see R resection in your textbooks, what it just simply means, when you say R1, now, when you do surgery, if this, let's say it's a lesion here, this is a structure, and this is a tumor here. You are to resect this tumor. This is a tumor. And you resected this place. You left a free margin. This is a tumor-free margin. Okay? Now, you are not seeing any gross tumor here. Grossly, this is the extent of the tumor. Maybe this margin you are leaving, for that recommended excision, they said 5 centimeters. Okay? So there is no any negative macroscopic margin. That is the meaning. There's a negative macroscopic margin because this is a tumor here. You left a resection margin. It depends on the type of tumor, 2 centimeters, 5 centimeters. So grossly, what you are seeing, you are not seeing any tumor at the margin of resection. That is R2 resection. It means there is a negative macroscopic margin of resection. That is what you do when you are treating malignancy. Now, R1, you are going to take this specimen for histological evaluation. When they evaluate, they will look at this margin to see whether it's free of cancer cells or positive of cancer cells. When it is negative, there's R1 resection. You have a negative microscopic now. So this is from histological evaluation. R3 resection is gross. You are just debulking. You are cutting, and you yourself, you are seeing that there is tumor there. You cannot take out all the tumor, so you report that as an R3 resection. It's just debulking of the tumor you did. So whenever you see all this R resection, it shouldn't confuse you. Now, when you do R2 radical resection, it means you are resecting. You have to get a negative macroscopic margin. Macroscopically, you are seeing free margin away from the tumor. That is R2 resection. Okay? So it's recommended for a curative resection. And tumor has not spread beyond the stomach. Okay? You have to do a radical end dissection. Okay? It's recommended for a patient fit for such operation, including a tear of non-involved lymph nodes. Now, let me also tell you what this means. It's very important you know, so that you don't be ignorant of that. Now, these nodes are categorized, the lymph nodes are categorized as N1, N2, N3. Okay? When you see lymph node that are within 3 centimeters, okay, from the tumor, or if you are to use, let me show you that TNM again. Let's go back to that TNM so that it will be clearer. I told you when you are doing the treatment, that will help you. Now, N1 is regarded metastasis to 1 or 2 regional lymph nodes. That is N1. And this is within 3 centimeters from the stomach wall. When you say N2, it is between 3 to 6 regional lymph nodes. N3, it is more than 7 regional lymph nodes. 3A, 7 to 15, B, 16 and above. There are up to 18 stations of lymph node. Now, when you are doing D1 dissection, lymphadenectomy, you have to remove all the nodes in D1. Okay? All the nodes in D2. When you are doing D2 dissection, you remove all the nodes in D2 and the nodes in D3. Okay? When you are doing D3 dissection, you are going to remove all the nodes beyond D3 and even D4. That is when you say it is curative. You cannot remove an involved tier of lymph node and think you have cured that tumor. It must be including a tier of non-involved lymph node beyond that may be involved. So if you are doing D1, okay, D1 resection, you are going to remove tier 1 and tier 2, N1 and N2. Maybe N1 is involved, N2 is not involved. You call that curative. If you are doing D2, you are removing both D2 and D3. That is when you say you have done a curative treatment, because maybe D2 is involved and D3 is not involved. And you should go and read this. Now, at least 15 lymph nodes should be removed for histological evaluation. Okay? So most of the tumors, as we mentioned, especially in our environments, they are in what? Distal 1/3. Okay? And when you are removing a distal 1/3 tumor, you must leave a margin of 5 centimeters. If it is intestinal type, and if it is the diffuse type, the more aggressive type, you must leave a margin of 10 centimeters. That is the R2 margin. You must leave a margin of 10 centimeters. If after taking margin and the distance between the cardia is less than 5 centimeters, then you do a total gastrectomy. Okay? So the proximal resection margin is 5 centimeters beyond macroscopic edge for intestinal type and 10 centimeters for infiltrative type. The proximal 3 centimeter of the duodenum is resected with the stomach, as there may be subserosal spread to the duodenum. R2, D2 resection is done. If proximal resection is less than 5 centimeters from the cardia, total gastrectomy with Roux-en-Y esophagojejunostomy is necessary. The above procedure is same for tumor in the middle third. For proximal one-third tumors and linatis plastica, a total gastrectomy is done. Now, when you do surgery, you assure your patient. When do you tell your patient that your surgery is curative? Okay? When you do surgery, it could either be an absolute curative surgery or a relative curative surgery. During the surgery, there is no deposit in the peritoneum or the liver. There is no serosal involvement, and you remove a tier of non-involved lymph node. Maybe N1 is involved. You now did N1 and N2. You now proceed to remove N2 group of lymph node. So when you do such a thing and you resect the tumor with a R2 margin, you say you have done an absolute curative surgery. A relative curative surgery, you just remove only the involved lymph node. You do not go beyond that tier of lymph node. It's relative curative. Even if this is not involved and you remove only this, it's not absolute curative. There are some terms you need to know in non-curative cases. If there's evidence of a residual tumor, it is non-curative. Maybe you do an R3 resection. There's gross tumor, it's a non-curative surgery. Now, you should understand the difference between inoperable tumors and unresectable tumors. Inoperable tumors, the patient is not fit for surgery. Patient factor. Is frail, okay? There's lymph node everywhere, carcinomatosis peritonei, ascites, Sister Mary Joseph nodule, liver metastasis, okay? Advanced disease, so it's inoperable. You can't even operate. Patient is not even fit for surgery. Unresectability, the patient may be fit, but it's a tumor factor. Maybe the tumor is encasing a major blood vessels that you cannot resect it. So it's a non-resectable tumor. So for this kind of cases, you just treat with chemotherapy. The prognosis of gastric tumor is poor due to early spread and late presentation. You can see 25% are alive in 1 year, 10% in 5 years, only 5% in 10 years. Even in the absence of spread, when they are peak early, 5-year survival is 60%. And the prognosis depends on degree of invasion of the tumor, nodal metastasis, spread of the tumor, duration of symptoms before presentation, degree of differentiation, and the response to chemotherapy. So in summary or in conclusion, gastric tumor is the commonest cause of cancer death, okay? It's an aggressive tumor and used to be called the captain of the men of death in the past. It has a poor prognosis because of late presentation and early spread. There's one of my professors that used to tell me that the stomach don't forgive. Gastric tumor, when you resect them, most of the patients do not do well. And it's a tumor because of the poor prognosis. Most of the targets are tending towards preventive measures. Because if you look at all the risk factors we mentioned, a lot of them are preventable. So we are going to stop here. If you have any questions, clarifications, you can unmute yourself and ask. Thank you, everyone, for participating. So we've come to the end of these lectures for today. Any question? Okay, it appears we don't have any question. So